it will be something which will connect you with obesity. How we look at obesity as clinicians, as cardiologists, as physicians, and in the last comes the bariatric surgeon, because majority of the patient, we are the gatekeepers. Jaiswal spoke about genetics and epigenetics. What he said was 100% truth until unless you have monogenic disease. If you have hemophilia, whether you have epigenetics or no epigenetics, it will manifest. If you have familial hypercholesteremia, it will manifest. It's irrespective of the environmental influences. But most of the diseases are not monogenic. They are polygenic. And environmental factors, they play an important role. Leave aside environmental factor. The mental factors, how much you are stressed. So stress can precipitate any kind of obesity, stress can precipitate blood pressure, diabetes, cancer, anything you can imagine stress can precipitate, because 99% of our genome is silent. It doesn't work. We work with 1% of our genes. So if you activate your brain too much, you may use more of genome, and there may be a random placement of different disease-related genes, and they can manifest. So stress can precipitate cancer also. It can precipitate obesity also. Ozempic is the drug which is the prototype of anti-obesity drug. Like statins are for lipid lowering, because it revolutionized the concept that obesity can be treated like any other disease. And this is the year when Ozempic was, I think it is couple of years, and people talked about, now this year Santa will be too thin because he'll be using Ozempic. This is company wanted like this. Like any other disease, it's multifactorial, and the most important word is chronic and relapsing. You have to carry these two words home. It is chronic and relapsing. That means if your behavior is transient, behavioral changes are transient, if your drug therapy is transient, it will come back. Like diabetes, like hypertension. So like any non-communicable disease, it has to be looked after. We feel too much obsessed about bariatric surgery, but the same principle applies to bypass surgery also. If you don't look after your bypass, your angioplasty, it comes back. So non-communicable diseases cannot be treated like communicable diseases the way we use antibiotics. That is wrong. So you have to look after the procedure lifelong. That is the problem. From community's perspective, it is unfair deal. From medical fraternity's perspective, it is the best we can do. We know it is incomplete. We will wish that something should be done where a bypass is done, it is done for lifelong, like appendectomy, but it doesn't happen that way. So it's a non-communicable disease. It's a chronic relapsing disease. I was in fact brought up with the understanding that your weight is your energy passbook, calories in, calories out. So if you retain too much of calories, you become obese. That was the very simplistic understanding till we realized that it is a neuroendocrine problem. Obesity is simply seeing as a calorie game is too simplistic an approach. It is basically a neuroendocrine disease, and it has to be dealt with like diabetes, like hypothyroidism. Like we were talking of leptins. We unfortunately don't have a marker like HbA1c for obesity. We don't have a marker for cardiovascular atherosclerotic disease like HbA1c. So leptin, as rightly said, is one of the markers, and it may be a marker which may be a surrogate marker related to something else prior to it. So leptin at the moment correlates, but not the end of journey, because we are learning obesity and we don't have, like if you ask me what is the marker of hypertension, we don't have a marker for hypertension. We measure hypertension when it is there. It is not like that HbA1c, there is a pre-diabetic stage, you know this much, and then hypertension will come, it goes up, then it comes further. So unfortunately, what are your queries are genuine, but we are not advanced enough to answer that mathematical model. That you have to, leptin is the best marker, we have it, but not the perfect marker. In fact, there is a paper recently which talked about leptin as correlation with obesity. This is the best we have at the moment, not perfect. And as you know, overall CV mortality, obesity related mortality, it is going up. So बहुत सारे लोग हमको मिलते हैं अपने हमारी लाइफ में, they try to teach us, डॉक्टर साहब मेरी शुगर परेशान नहीं करती है. मैं नाम नहीं लूँगा, डॉक्टर एरन, मी, अमित रस्तोगी, we were involved in one VVIP lady care, and every time we visited her, she will defeat us कि मेरी 500 तो normal रहती है. And we tried her best, our best, and finally we gave कि अपने हिसाब से लेती रहिए मैडम, you are right. So there are people who are wrongly perceiving their illness as a friendly illness. Similarly obesity, डॉक्टर साहब हमारे तो सारे पैरामीटर ठीक हैं, हमें कुछ नहीं हो रहा, हमें कुछ नहीं हो रहा हमारे. No, it is not possible. You will have to pay the price for obesity in times to come. And obesity in somebody may reflect as a renal failure, somebody may reflect as osteoarthritis, somebody may reflect as immunological disease, somebody may reflect as diabetes. So obesity need not necessarily to have the whole spectrum of illness in each individual. Finally, every decade, one organ system will get involved every 5 or 10 years. Like if you are 80-year-old, I am told, if you are 80-year-old diabetic, if you happen to reach 80 years, my friend Professor Kamlesh Kunti, he said, Rajeev, each decade you add one system. So if you meet an 80-year-old guy who is diabetic, his 8 systems will be involved. Neuropathy, nephropathy, retinopathy, dermopathy, pulmonopathy. So he said every decade we add one system in diabetics. I think that applies to obesity also. We had been talking about hypertension. There is 40% increased CV event hazard, but somehow we are not that conscious of preclinical obesity. That is also very important. This is a very, very hot slide. We did not know till now that maternal obesity shortens the offspring's lifespan and accelerate age-related fibrosis. Young girls, 90 kgs. Somehow what has happened is, in the current society, young girls have lost that drive of looking beautiful. They have started wearing bigger and bigger and bigger, and they don't mind. When I was a young guy, I never saw an obese girl in a marriageable age. But today I find there is no problem. And if there is a disparity, the other spouse also compensates and tries to match with the other obese spouse. You don't find, very uncommonly, They match each other. And it is so unfortunate that young girls, one pregnancy, and you feel what a mess they have made of their body. They are out of breath. They are unable to walk around. They are unable to climb stairs. There is no glow, hirsutism, acne, acanthosis. They are ugly. And somehow that doesn't bother them. So your child pays for your obesity, which is a very important thing to motivate our patients. I am a lipidolic, obsessed with lipids, but this slide shocked me that obesity is the most important risk factor in atherosclerotic heart disease. It has outpaced lipids. Then there is obesity-driven autoimmunity, rheumatoid arthritis, 30% more incidence, psoriasis, 18%, multiple sclerosis, 49%, irritable bowel disease, 35%, and any autoimmune disease, 41%. So that is what I am trying to say and picturize before you, that it is the mother of all diseases. Wherever you look at, there is a mess. In dilated cardiomyopathy, the obesity does not correlate well with heart failure. But if you have another type of heart failure, what we call HFpEF, my colleagues on the internal medicine side would appreciate that it badly correlates with HFpEF. So what is HFpEF? HFpEF is nothing but in diastole, the heart is pliable, it accepts blood, but in these patients the heart is stiff, it doesn't open up and the blood goes back to pulmonary circulation, and these patients say, हमारे हार्ट का इको ठीक है, सांस फूल रहा है. We will say, ये फंक्शनल पेशेंट आ गए. हमने भेजा किसी फिजिशियन के पास, त्यागी जी के पास. त्यागी जी ने कहा इसके PFT ठीक है. वो कह रहे त्यागी जी कह रहे हैं ठीक है, राजीव अग्रवाल कह रहे हैं हार्ट ठीक है, सब हमारा तो सांस फूल रहा है. These are real patients. They are not, I am trying to create. So cardiologist is not owning these patients, pulmonologist is not owning these patients, and they are roaming around. And the one simple trick is, if it is obese female, diabetes, hypertensive female, it is HFpEF. It is HFpEF. And if you reduce obesity, they do dramatically well. If you reduce weight in HFrEF, it doesn't work. We do not know the answer, but it doesn't work. But in HFpEF, it does so well. So obesity, visceral adipose tissue, it has got a metabolic effects, inflammatory effect, endocrine effects, and that all causes very hostile neurohumoral system, which is having a cellular component also, and they create inflammation. जैसे आपकी body में आग लगी हुई है. Well, because it's a hostile neurohumoral system, and these patients are very prone for every kind of illness. Obesity, for the sake of simplicity, it has been described as no risk factors or disease, excess dysfunctional adiposity, excess or dysfunctional metabolic chronic kidney disease, metabolic kidney disease, subclinical CVD, and all that. But I strongly disagree with this slide, because this is not a continuum like this. You may start obesity with CVD and CKD following. You may start with obesity, CKD, CVD, or you may stop at obesity, CKD. So this is not a continuum as described. There is mix and batch, and my message is then you can have both the things preceding one another or all together towards the end of journey. Obesity, as you know, there are various classifications, but this is type 2. Indians or Asians, they have 2.5 kg per meter square less. So if you are more than 40 kg, that means 37.5 kg, it is class 1A indication for obesity management. Preferably bariatric surgery if you are diabetic, is class 1A. None of us do it. If you are obese, diabetic, uncontrolled, then it is bariatric surgery is class 1A indication. None of us do it. Very few of us measure BMI in our clinic. The biggest problem which we are facing is we are practicing medicine visually, empirically, experience based, vehemence based, eminence based, not evidence based, because we don't document these things. अगर आपके पर्चे पे 40 BMI लिख के आ गया, आपके कान खड़े हो जाएंगे. अगर आपके पर्चे पे 45 BMI लिख के आ गया, आपको करंट आ जाएगा, क्योंकि आप लिखते ही नहीं, आप कहते मोटा है. I saw a young boy today, 145 kgs, 22 years. So until unless you document it, you will not. जैसे आप LDL नहीं लिखेंगे और देखेंगे नहीं तो पता कैसे चलेगा LDL कितना है. तो आप BMI लिखते ही नहीं. एंड मैं हर आदमी को कहता हूं, एक ग्रेजुएट अटेंडेंट अपने वेटिंग चैम्बर में रखिए. ये सब मार्कर्स कंप्यूटर ड्रिवन है, जैसे कंप्यूटर पे होता है, कट 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 करिए निकल के आ जाते हैं. और आप अपने उन बच्चों को ट्रेन करिए कि यार इसका जरा चैट स्वैक स्कोर निकाल दे, इसका हेफपेफ स्कोर निकाल दे, इसका ब्लीडिंग रिस्क स्कोर निकाल दे, इसका हाई थ्रोम्बोटिक रिस्क स्कोर निकाल दे, इसका पल्मोनरी एम्बोलिज्म. कोई करता ही नहीं. और यार मैसिव लग रहा है पल्मोनरी एम्बोलिज्म. कैसे लग रहा है यार? लग रहा है मैसिव. स्कोर कोई नहीं करता, जबकि ये इतने सिंपल स्कोर्स हैं. You do not need wisdom, you just need somebody who knows English language and basic computers. It takes less than a minute. So until unless you measure obesity, you won't be able to treat obesity. So obesity has got cardiometabolic diseases like this, and obesity has got on multi-system reach. Infertility. And we know that visceral obesity, as Dr. P.K. Gupta said, ABC. We have two types of fat. One fat which is under the skin, which is called subcutaneous fat. There is another fat which is called visceral fat, which is around the organs. Somehow, Indian phenotype, our capacity to hold subcutaneous fat is low. And the moment it goes beyond a certain limit, our fat, instead of increasing in subcutaneous compartment, it moves to visceral compartment. Why it happens, we don't know. It is just a morphological data. So we cannot answer everything. So the same amount of weight, same weight, Indians will have more visceral fat than our counterparts. And that's why we are more in trouble. And you can see obesity has come now in the center stage of management of heart diseases. This is one thing which is very beautiful, you should remember. This is 7 a.m., this is 7 p.m. So this is day, this is night. Timing matters, and what you see, if you are a night eater, then insulin resistance, lipolysis, free fatty acid, that's why the fasting sugar is high. So the body biorhythm dictates that we should not eat in the night. So it is always good idea to have Jain concept of eating, that you should finish your eating 2 or 3 hours before sleep. Vinoda is sitting here. I thought I'll finish before her. Probably she is listening to my first talk ever. So मैंने सोचा था मैं बोल के खत्म हो जाऊँ, because I eat in the night. So there is always a diurnal or a circadian rhythm. And what happens? 1 week of short sleep in otherwise healthy adult. Sleep deprived by strict definition, just 4-5 hours a night. What happens? 28% ghrelin, hunger खूब बढ़ेगी, overeat करेंगे. 20% decreased sensitivity, muscle protein synthesis down by 20%, decreased testosterone, increased cortisol. So sleep is very, very important. You should sleep like a child. It is anti-obesity measure. It is anti-diabetic measure. It is anti-heart measure. It is anti-hypertension measure. उसको भी डांट पड़ रही है साले को. Nephrologist भी डांट खा रहा है इसकी. You should not sit with your wife. Never sit in such kind of lecture with your wife because they will be troubling you. So Sandeep is also being harassed. And what is most important is sleep matters first. If you exercise and not slept well, exercise doesn't work. That is another beauty. If your sleep is more than 6 hours, then only exercise works. So sleep in fact is a system where your biorhythms are reset. And if you conflict with them, you will be in trouble. And try to be in biorhythm. If you sleep in the day, every day, fine. But you can't change your biorhythm. The body gets confused. Your melatonin gets confused. You know, babies who sleep more are taller because the growth hormone is secreted during sleep, not awake. So babies who sleep more, they are taller than the babies who sleep less. So the more you read of circadian rhythm, the more you find that circadian rhythms are biological clocks. If you are in conflict with your clocks, you are fighting with your body, you are fighting with yourself. Like if you ask me to come for a lecture at 7 a.m. in the morning, I am half asleep. I can't. Because my circadian rhythm doesn't match that way. So, ladies and gentlemen, till now we were associated with this understanding, lipid ठीक करो, triglyceride ठीक करो, colchicine दो, anti-inflammatory, diabetes ठीक करो. But what we realized, the real elephant is obesity. If you treat diabetes, you treat diabetes. If you treat hypertension, you treat hypertension. But if you treat obesity, you treat all of them. That's why it is the mother of all diseases. So obesity is very, very important, and you see what we gain as the percentage of weight loss increases, dividends increase. As I told you, if you lose 25 to 35% of your weight, even cancer risk reduction is there. MACE reduction, NFLD resolution, it disappears. Sleep apnea, and that is what, if you lose more than 30% of your weight, complete diabetes remission is seen in 80% of the patient. So the best treatment of diabetes is walking. It improves insulin sensitivity, and muscles are the most important anti-diabetic organs. When I was a student, I learned liver is the biggest endocrine gland. Then I grew further, I realized endothelium is the biggest organ. And now I know that bones and muscles, they are the biggest endocrine glands. Muscles specifically, they secrete so many good hormones. So there is an incremental benefit with different way you look at. They are the drugs. Today we have two drugs in India, largely semaglutide and tirzepatide. This is more powerful weight reducing than semaglutide, and each 1 kg weight loss decreases mortality by 3.4%. Each 1% HbA1c decrease reduces 7.6% of mortality. So it translates because it is multifactorial. And if you treat obesity, naturally you treat so many things. The newer drugs like sema and tirzepatide, they reduce CRP to the tune of 40 to 60%. Most powerful, many times more than statins. So आपके जिस्म में जो आग लगी हुई है वो एंटी ओबेसिटी मेजर्स से body on fire. Inflammation means body on fire. So that will reduce your inflammation maximally by weight reduction. Obstructive sleep apnea. Obstructive sleep apnea is a disease wives and spouses can diagnose. ये तो इतना खर्राटे मारते हैं जी, मुझे दूसरे कमरे में सोना पड़ता है. आप दूसरे कमरे में सो तो गए, लेकिन he is CV risk. He has more chances of diabetes, he has more chances of sudden death, and it is a reversible cause of dilated cardiomyopathy. It's a reversible cause of atrial fibrillation. I am not saying for the sake of saying. Gagandeep 15 years back had atrial fibrillation, young boy, and he was obese. And I told him, you reduce weight. And it's 15 years, he never had recurrence. He reduced weight, he's a gymmer. Every night, every evening, he is in a gym. I don't know what he is doing now, but for many years he did, and there was no recurrence of AF. So obesity is related so much with these things, and if you reduce, as you get more of visceral fat, and you can have this thing. And who are the best person to diagnose obstructive sleep apnea? Tailors. If your neck is more than, अगर कॉलर का साइज बढ़ रहा है, हस्बैंड बीमार हो रहा है, हीरो नहीं हो रहा. If you are more than 16 inches female and more than 17 inches round on this bone, then you are obstructive sleep apnea. Nai, they should be taught acanthosis nigrans on the back. मैं अक्सर लेडीज को कहता हूँ, जब मेरे पास अगर मैं कहा जब तुम्हारी शादी हुई थी इतने ही काले थे, बोली नहीं सर अब तो सब या माथे पे भी हो गए हैं, ये हो गया. मैंने कहा फिर गोरे हो जाएंगे, इनका वजन कम करा दो, बिकॉज दिस इज acanthosis nigrans. So somehow the tailors and the barbers can be a very important surrogate help for picking up these things which they go very unnoticed. माथा काला हो गया, बिल्कुल काले हो गए और दिख नहीं रहा है. And you reduce weight, you regain your color again, because that acanthosis nigrans, this, that, this, सब इतना हो जाता है कि आपको दिखाई नहीं देता. Another thing is, जब हम ये दवाइयाँ देते हैं, आजकल गट का भी बहुत इंपॉर्टेंट रोल है एथेरोस्क्लेरोसिस और इन्फ्लेमेशन में. गट के हार्मोन्स बहुत पॉजिटिवली चेंज हो जाते हैं एंड आपकी एथेरोस्क्लेरोसिस इन्फ्लेमेशन कम हो जाता है. ये भी देखा गया है कि जो लोग वेजिटेरियन डाइट खाते हैं उनका गट का फ्लोरा बहुत फेवरेबल रहता है, उनका इन्फ्लेमेशन नहीं होता. सो नॉन वेजिटेरियन डाइट, वी हैव वेरी स्ट्रॉन्ग एविडेंस नाउ that it is a bad diet. I'll just couple of minutes. This is obesity and cardiovascular disease, and you see there are different drugs, how they reduce weight. These are bariatric surgery. So bariatric surgery no doubt outscores. जैसे आपको पता है इसका HbA1c 14 है, तो आपको पहले दिन पे पता है यार इसको इंसुलिन लगेगा, कुछ नहीं हो रहा. ऐसी अगर आपका BMI 40 है, 45 है, यार दवाइयों से कुछ नहीं हो रहा. He is a candidate for bariatric surgery. You know on day one. Don't be a fool. So that is how these drugs they reduce blood pressure, LDL cholesterol, HDL, TG, and that is how it is done. There are so many drugs in pipelines, but two drugs which we are using are semaglutide and tirzepatide. One problem we are facing is we want diabetics to be losing more weight, but unfortunately all drugs they reduce weight more in non-diabetics than diabetics. We do not have the answer, but that is the problem. So all these dark blue are non-diabetic and these slate gray, they are diabetic. You find whatever you want to do, Even in bariatric surgery, Roux-en-Y, you have more weight loss in non-diabetic individuals. So, but that is a problem, we can't help it. This is the best we can do. And we are fortunate now. Semaglutide has come in such a big way, and Indian pharmaceutical industry is to be complimented. We are not innovators, but we are exceptional people in biosimilars. Nobody in the world can produce quality medicine at a price we can produce. You can have amlodipine 5 milligram for 50 paisa. साला पानी का बताशा नहीं मिलने का. So, if our patients are not getting an appropriate drug therapy, it is really very sad on the part of clinicians not to create a prescription befitting their pocket. Because we are living in a country where drugs are at a price where garbage is costlier. Semaglutide, no country in the world can have at this price as we are having. And why semaglutide? Anything you name. And you see these companies, they are growing worldwide like anything. After smoking, obesity is among the most important preventable causes of cancer. आप समझ रहे हो क्या कह रहा है? यानी कैंसर में, आई एम नॉट टॉकिंग ऑफ सीवी डिसीज, कैंसर में ओबेसिटी इज सेकेंड टू ओनली स्मोकिंग. इतना पावरफुल कोरिलेशन है. There are different ways to look at which drug is superior, which is inferior. I'll think you have not to start alone. Our clinician colleagues will guide you which drug you need, and we have enough exposure to these drugs, and all our colleagues will guide you which is the molecule out of these two you will use. Another out of label use is post pregnancy. I touched upon that ladies are using ad hoc Ozempic after delivery for weight loss. That is out of box, off patent misuse of the drug, but that is happening. Mothers in the 6 months after delivery, and you see the meteoric rise of usage of these drugs. I am not justifying, just orienting you people that this is what is happening. So, if obesity is a chronic relapsing disease, why we are treating it like antibiotics? You can't. You should not blame in दवाइयों के साथ ऐसा होता है, ये होता है. अरे डायबिटीज की दवाइयों के साथ नहीं हो रहा, ब्लड प्रेशर की दवाइयों के साथ नहीं हो रहा. Why you are so upset about it? That is a limitation, but this limitation applies to every medication we do. If you stop medication, then it bounces back. So whatever weight loss you do, it bounces back. And if you do behavioral therapy with weight loss, these patients do extremely well. Otherwise, whatever you gain, it comes back within 2 years and maybe overshoot what you started. So you have to mentally convince yourself that I'll prepare this patient for a very long or a lifelong intervention. Then the patient is to be comforted with that it is a lifelong medication. And that is what happens. Continuous use of 3 years of these drugs, you lose 18% of risk reduction. You get 18% of risk reduction. If you stop in 2 years, you rebound to 22%. तो भैया यूज नहीं करना है, आपका मोटिवेशन नहीं है, मरीज का नहीं है, मत यूज करो. बट एक बात अच्छे से समझ लो कि ये बंद नहीं होनी है. I told you may mass the patient, and what you gained in 3 years will lose in 2 years. So that is very, very important, that it can't be very casual. अच्छा यार 2 महीने लगा के देख लो, अच्छा 6 महीने लगाते हैं. Be firm, because if he goes to you, you will say full lifetime. If he goes to him, lifetime. If he goes to her, lifetime. Then patient realizes it is lifetime. I never talk to my patient where say, Doctor Sahab, दवाई में सारी जिंदगी. I slap them with the knowledge and advise and paste them. That is lifelong, कोई confusion नहीं है. So unless we do that, we won't be doing justice. Bariatric surgery, as Rishi has done wonderful job for the city, for the country, for all of us. We are proud of him that he has done some wonderful bariatric surgeries at a price, at a place where we thought this is altogether. If I look Meerut, I find the way when we came, cardiology started coming up, same way I see his contribution in the whole Western UP, bariatric surgery coming up as a new specialty, which is a standard. He is not something he has created on himself. This is a standard procedure which he is doing. So this is altogether new dimension and medical growth that bariatric surgery is being done, and bariatric surgery has got very low mortality, is less than CABG. So bariatric surgery is a very good surgery, and bariatric surgery increases the life expectancy in patient, 9 years in patient with diabetes, 5 years in patient without diabetes, despite having lower weight loss in diabetics. I have taken out one study to justify that bariatric surgery is not a cosmetic surgery, it's a metabolic surgery. How it reflects: primary 8 years follow-up, primary composite endpoint, metabolic surgery patient doing well, secondary endpoints, metabolic patients are doing well, all-cause mortality, heart failure, cardiovascular disease, coronary artery disease, nephrotoxicity, atrial fibrillation. All these parameters are looked after very well for a follow-up of 8 years with bariatric surgery. And non-surgical, and weight is more or less maintained for up to 8 years, and HbA1c is there a little bit of overshoot back, but even then it is better than this. And now we understand that metabolic surgery is to be sandwiched with GLP-1 receptor analog, like polypill approach in hypertension, diabetes, coronary artery disease, lipids. Now we believe that multiple axes will be addressed together, not one axis. So this is a high time that we understand that GLP-1 receptor analog will start and follow after the bariatric patients in an appropriate patient. So non-insulin diabetes medication reduced, insulin reduced, other antihypertensive medication reduced, renin-angiotensin system inhibitors reduced, lipid lowering drugs reduced, and this is aspirin usage reduced. So ladies and gentlemen, obesity is a mother of all illness, and it is the Achilles heel. The simple thing you connect with obesity is make a routine of measuring BMI in your clinics, then you will automatically attracted towards it. If you don't measure it, you will continue to be the vague that मोटा है, उसको quantify नहीं करेंगे तो आप नहीं करेंगे. Food is the most abused anxiety drug. Fasting is the most forgotten cure. Exercise is the most underused antidepressant. And each 1,000 steps you do, it reduces morbidity and mortality. Walking is the essence and elixir of life. If you do more steps, everything is reduced. So when we do bariatric surgery, it does not undermine lifestyle modification. We are no way suggesting use semaglutide and forget exercise. Exercise starts, exercise follows, and you have to be with the frame of mind that we are not bypassing exercise. We are talking hormones these days a lot. Recently I got this photograph that there is a single malt called whiskey, not permitted when you are doing an anti-obesity measure. And ladies and gentlemen, I end up that I have tried to remove the mud out of water, and I'm sure you must be having some kind of understanding about management of obesity. And I have so many teachers and seniors sitting in the audience. I have learned so much from them. Dr. Mitra is sitting, Dr. BP Singhal is sitting. And I have learned so much from them, the art of speaking, understanding, analyzing, that I in person remain always grateful to my teachers, that whatever we are today is because of them. Thank you very much.